Welcome to Decoded, the podcast that decodes the design, technology, and experiences shaping our world and planet. I am Melisa Leñero.
And I'm Saeema Ahmed Christensen. Together we explore the systems, behaviors, and technologies influencing how we live, work, and connect, from human interactions to the ecosystems we are part of.
Each episode is a conversation with technologists, designers, entrepreneurs, and everyday users. Join us.
Hi, welcome back to the show. I'm Saeema, a professor of design engineering and innovation and director of DigitLab, exploring design and digital technologies based in the University of Exeter.
And I am Melisa. I'm a designer by training and currently rediscovering what design is in times where the world is challenged in many different ways, from the artificial intelligence revolution to deep societal changes and massive ecosystem destruction.
In today's episode, we'll be exploring the theme of design and systems thinking and the role they play in the design of healthcare systems with our guest, Professor John Clarkson. Welcome, John.
Hello.
John rejoined the Department of Engineering in the University of Cambridge after spending 7 or 8 years with the PA Consulting Group in the Technology Division, and he was appointed a full professor in 2004 and director of the Cambridge Engineering Design Centre in 1997. He's been involved in all sorts of levels of teaching in Cambridge University and holds a position of healthcare systems professor in IDE, Industrial Design Engineering at TU Delft. And through your time in industry, you've worked extensively in medical equipment and understanding high integrity systems with clients, particularly on risk-based systems approach to design. John's research interests are in the general area of engineering design, but particularly around methodologies to address specific design issues. For example, healthcare design, inclusive design, and process management, with over 800 papers and a number of edited books in the area. So John also led a team with the Royal Academy of Engineering and the Royal College of Physicians and Academy of Medical Science to develop Engineering Better Care, a systems approach to healthcare and redesign and improvement, which is the center of our conversation today. Alongside this, your work's been recognized through numerous awards, including the President's Medal, from the Royal Academy of Engineering, and most notably a CBE. So I think you are our first CBE on the podcast in the King's Birthday Honours from 2024. Welcome, John, to the show.
Thank you.
So, John, engineering design is a field that's often applied to complex products. So you'd think about it in terms of aerospace or consumer products and systems and the design of new systems. A lot of your recent work is focused on healthcare and increasingly so in healthcare. I wonder if you could start by discussing how systems thinking and engineering design can support the design of healthcare. And maybe we could start by saying what those two areas are.
I tend to avoid the term systems thinking and even probably systems engineering. And part of the reason for that is that I grew up in industry trying to figure out what systems engineering was. And the classic V model. And it's a brilliant diagram. But to be fair, it took me about 5 years to really understand the nuances of what's being said in that diagram and how you apply it in anger. And I also find systems thinking rather restrictive. So I tend to refer to things as a systems approach. So it picks up elements from these different areas. And it's a wrapper around what people are doing. And the idea behind it is we don't tell people that what you're doing is the wrong thing. We're saying, well, you may be tackling the complexity of the system in front of you, may be trying to improve it. What we'd like to do is to see if we can help you do that even better. So hence a systems approach to improvement is something that adds value to existing change profiles. And I think the ambiguity of whether it's a technical system or a socio-technical system or socio-socio system, I'm completely ambivalent to that. And I think that's just happened over a long period of time when I've been exposed to challenges of all different shapes and forms. But I remember a particular meeting, it must be 15 years ago or more, with the then Chief Medical Officer, Sir Liam Donaldson. And we were talking about systems approaches to patient safety. And he asked me in his office, his grand office in the Department of Health, what was this to be applied for? And I just sort of kept thinking throughout, it's about protocols, it's processes, it's procedures, it's committees. I went through a whole list of things that were nothing to do with engineering or technology. And eventually I said, yes, and it's about medtech. And the smile on his face was just extraordinary. Really is what he wanted to hear, that that sort of thinking, that systems thinking, can be applied to almost anything. And for me, that was a reassurance that that's what I had thought, in a sense. Yeah, technology is an easy thing to hang your methods on. It's much more interesting and challenging to have a socio-technical system where human performance, human motivation, human interaction has as much to bear on what happens as anything else.
And how does engineering design fit in there? So what are the sort of key sort of methods? And I mean, engineering design as a discipline probably has been around since 1970s, roughly.
Oh, long before in Germany, probably long before.
Yeah.
So I used to ask my researchers what comes first, systems thinking or design thinking. And I never told them at the time, but I didn't care what they answered. I was just more interested in the reasoning behind it, because if you start thinking about systems, you have to think about design. If you start thinking about design, inevitably you have to start thinking about systems. So I think they bring different perspectives. And that's what came to the fore when we did the work with the Royal Academy of Engineering, which became known as Engineering Better Care. That going into that, I think it was the third attempt the Academy had made to try and bring design systems thinking into health and care improvement. And it sort of got stuck both times before. And the difference was, what we determined is we were going to start a series of conversations with health and care professionals and improvers. And I looked at long and hard at the systems V model, and I just said, we can't start from here. It'll get in the way of those early conversations. So because of all the research we'd done until that point, I just said, look, why don't we look at it in terms of 4 perspectives: people, systems, design, and risk. And so, well, what do we learn if we look at it from those different mindsets? So you could argue that could be about design thinking, systems thinking, risk thinking. As soon as you put the word thinking there, you bring a lot of baggage as to what do you really mean by that. But I wanted to keep it simple. So we said, look, okay, so when it comes to design, what's the core of what we think design could be described to be? And we went back to the double diamond model, because we wanted to be a bit provocative and say, well, actually, it's as much about the translation of the need to the problem as it is trying to find the best solution. And that model, it's just brilliant, and it's challenging you to think it's as much about problem seeking as it is problem solving. On the risk side, we finished a big piece of work for, I think it was one of the big healthcare funders, around risk and engineering methods of risk. So we had a series of simple questions that we thought might capture that risk perspective, which basically says you need to know what you're looking at. You poke and prod it and see where it might break, where things go wrong, and then you decide what you can make better. And on the system side, the other thing is to think about the system and say, well, it's as much about the elements or parts and how they fit together as it is about the people who have interest and influence in that system, and then how does it perform. So each one of those perspectives is very much incomplete, but it gives you a window into what's going on. And then at the heart of it is all about people. It's about the diversity of, in healthcare, be the patient population, but also the provider population. It's the diversity of location or scenario, hospital, or where the care is taking place. So having chosen to do that, we ran a workshop in each one of those areas where it really was a set of conversations. So, for example, in the risk workshop, we had a few engineers talking about things they'd done to reduce risk in complex systems. And we had just as many healthcare professionals telling their stories of taking risk out of particular pathways of care. And through that dialogue, we started to understand each other. And I had determined before then, partly because it was already in our research output, that we would use questions to capture the heart of each of those perspectives. So it wouldn't be a technical language. It would simply be a set of 3 questions that we could agree on to capture that perspective. And that's what we did. And what came out of that was something that I would call the systems approach. It's hard to argue in that raw form of engineering better care that it's a process. It was more a set of ideas about what a systems approach might be rather than how you would execute it.
That sounds well-rounded. And actually, I was going to ask you if you could give us more examples, but you dive into the examples, right? Can I then ask how that sounds so neat and clear when you're explaining it? How do you then translate that into a practical area or a practical system that people will adopt? That it's not only some people using it, like healthcare is everywhere. We have it in all the countries. So how do you translate that could, roll out in different countries?
So there's an interesting challenge here. I guess when you're at the beginning, but has emerged more as we've worked with practitioners, the first thing we want to do is to raise awareness of people of what a systems approach might look like. So the Engineering Better Care report does exactly that. And there's lots of case studies in there to show how systems design, people, and risk apply to different case studies. But the purpose was just simply to raise awareness and say, when we look at improvement, when we look at complex systems, these are things we should be aware of. And the simple questions in there were organized to separate them subtly between the problem seeking and the problem solving. So it was also saying, look, don't just jump in with the first answer you think to the problem. Let's go back and see if we understand what the problem is to start with. So that's raising awareness. But behind the scenes, what we're trying to do then is raise a cadre of people who has more systems leadership qualities. They can do that translation into programs of improvement. And interesting, the systems leaders, they're not linked to the organizational structures in a sense. You may need the CEO of the hospital having systems leadership qualities to give permission for things to happen across boundaries. But it may be the chief nurse in a particular area of the hospital who needs to be the leader, the person who's crossing those boundaries, having the conversations, joining up the thinking, or it might be an individual physician. And so we're trying to raise the awareness. And what we realize is when we published the Engineering Better Care report at the back end of 2017, it really was the what is a systems approach. And I got permission from the Academy to bring the work back into my own group in the Engineering Design Centre here at Cambridge to think about the how. And we've had a history of designing toolkits for inclusive design, for risk assessment. And we thought, well, what would the toolkit look like in response to engineering better care? So engineering better care is a set of questions, and you can formulate them around a process of improvement from the current performance to something measurably better. And then we thought, well, we'd better put some process in there. So understand the context, define the problem, develop the solution, collect the evidence. And that's a nice iterative, simple design process, and underpinned by make the case, manage the plan, and most importantly, agree the scope. And in all of that is still a how. How do we do it? How do we coordinate and organize that? And what we found is that the best way to do that is to show people why these perspectives matter. So run a set of interactive exercises with known engineering products to show why thinking about the system, the risk, and the design matters. And then we simply say, on one piece of paper, tell us what you know about the context, the problem, the solution, the evidence, the case. And with no boundaries to that thinker. So if they think they have the answer, we write it down. But the answer to what problem? Or if they don't know what the problem is, at least tell us about the context and tell us what you can measure. Tell us what's important. And we find what we call the improvement canvas, where we try and capture this information, is the starting point for people at any level to try and figure out where they are in this complex problem-seeking, problem development, problem-solving arena, so that they then can start to plan how to progress.
Can you talk more about the canvas? Because the follow-up question that I wanted to ask is, you talk about designing the problem or defining the problem, which this is also something that I do a lot in my at work. So how do you, if people are not aware of the system and you're talking about a new term, but at the same time you really want to hone in what is a problem, where do you start?
It's a great question. One of the things we always do is start with the stakeholders. So it's often easier starting with the people than trying to describe the actual system. So the classic of saying, well, who are the stakeholders? Who has interest or influence or lack of either of those in the system you're trying to develop? The one we take that slightly further is who, as a particular stakeholder, I need so that. So we're trying to understand the stakeholder needs, but we're trying to capture at least our interpretation of the rationale that might sit behind it. So you
And the
might argue,
incentives.
yeah, it is. And so as a GP, I need patients so I can make them better. Or as a GP, I need patients so I can make money. There can be multiple reasons behind those statements of need. And it's really important to try and understand them, and also the position of those stakeholders in terms of their interest and influence, accepting that they're not always homogeneous. You may have different versions of the truth for the same stakeholder. And part of what we're doing there is to get them thinking about the diverse needs of the stakeholders, but particularly some of the rationale behind it, and trying to distinguish between the wants and the needs. And at the same time, we start to build up the system. And in healthcare, one thing that's really important but challenging is that distinction between the patient journey and the healthcare pathway. So we have these fragments of pathways that we interact with, but it's the journey, the lived experience of the patient that really matters. So we start to get them to think about what the journeys might look like in the area that we'd be focusing on. And one of the things I'm trying to do is to get them to balance the stakeholder needs very early on and try and distinguish between the ones that really matter and what they're trying to do and the ones that don't, the ones that either will never be useful or you have to park them for a future program or project. Sometimes it's about having those difficult conversations early and trying to say, well, what is the real thing we should be focusing in on? So often you get people putting all of this contextual information and challenge in the problem box. And we spend a lot of time then just talking about, well, how much of this is context? How much is actually the problem you need to solve over the next few months? And it's a conversation, it's a discussion. There's often not a clear answer, but you want them to start to figure out, well, how do we get to that definition? And do I even have the right people in the room to talk to help me get to that point? So it's not a mechanical process. It's more a process of exploration and trying to figure out, well, of all the things we could do, what's the one that matters most? And often what we find is it's not about solving the big world problem that they're there to solve. It's something much different.
Yeah,
It
so
might,
like reframing the problem as you do, and how you've described that approach with the stakeholders and bringing those people together. Do you bring them together in the same room? Can they hear what's conflicting between one group and the other, or how do you then resolve? You've talked about parking the requirements, or um, I've run also workshops with healthcare people across healthcare systems, including patients and people with lived experience. And you can get very different needs, and they're all trying to work towards the same goal, but the reasons and what each group may need can be very different, as you've just articulated. How do you deal with that next bit? How do you deal with what's parked, and how do you deal with getting consensus in that group?
so there's two parallel questions there. One of them's very early on is you often only going to get a certain number of people in the room. And we distinguish between the team and the stakeholders. And the question is always, having figured out who the key stakeholders are, do you have enough of them in the room, or at least proxies for them in the room to continue? Or do you need to bring more people into the conversation? So it's really important to get the appropriate representation. And that often is quite dynamic. It can change through the course of the program. One of the other things we do is, having collected the people together and put them on the table, and we ran, as an example, a whole program around frailty, looking at frailty. And this was up in the Northwest. It was Lancashire and South Cumbria. And we had teams of up to 14 around the table, and another team might be 6 or 8. And one of the things we asked them to do very early on was to draw a rich picture of the system. It's a scary thing to ask, because or you suspect most people can't draw. But the reality is, you put a team of people around the table, they start drawing. And they start drawing the fragments of the bits they know, and they start trying to join them up, and then they start again, and they do it again. We often say, look, just put the patient in the heart of it and let's work around it. And that does two things. It allows all the voices to be heard, and there's different perspectives to come out. But it also allows you to have that conversation about, well, what is the part of this we should focus on? What are the key roadblocks? Where are the key areas for improvement? And it's not such a hard conversation then to focus the scope down to something that might be smaller than the whole. And people are more accepting at that point of why their priority might be excluded at that point in time. And I think the face-to-face makes a huge difference when you do this. The expressions, the passion, the excitement of people discussing a common challenge around the table can lead to a much better outcome in terms of agreeing, well, what do we do next?
Yeah, you are describing almost my day-to-day. I work in different countries, like in Ghana and Kenya, Cambodia, and it's exactly that, like bringing different stakeholders, key stakeholders, and also users to come to an agreement and defining, but what is the actual problem that we're trying to solve here? And government officials, and from national to local. So yeah, I feel that I'm taking notes of, okay, I'm going to start using this, or like some of the tips that you're giving. But you go ahead.
There are things that can surprise you, though. And we ran a program a while ago on palliative care. And so, well, how do we make improvements to palliative care? And of course, then you need to bring in the care providers who are part of that broad system, and there are multiple elements to it. We've got quite a few internationals in, and inevitably, those who've been through palliative care in a sense haven't survived. So you have the close family, the carers in the room. And as we got to know these people, we had 50 people in the room, I was asked to start to play out some of engineering better care. And I kept thinking in the back of my mind, what I really want to ask is, what would delight you in palliative care? And I thought long and hard about this, and took advice from my key minder, who's a GP expert in this area.
What a beautiful question.
Well, we did ask the question, and 3 hours later couldn't shut people up. And the flip side is, what would disgust you in palliative care? And those really emotive questions just freed people up to have that conversation. And we all had stories and narratives we could talk about, personal narratives that said, yeah, that delighted me. In the hardest of times, the darkest of times, that little spark of delight. So how would you enable other people to see that and share that? It's part of the normal way of working. And so, yeah, I would try that more and more often now, delight and disgust. I didn't know whether it would work, and it just put such a smile on my face after that event. Yeah, definitely would try that one again.
But you've just mentioned, it's really fascinating, John, because it reminds me when I was in RCA, one of the student projects was on end-of-life care. So experience there, it was interesting because, like you've described in your conversation with the chief medical officer at the time, how you realize, or how you both recognize the value of systems of engineering design approaches beyond technical systems. And in that role, I was at first apprehensive about what can I, from my background as product development in design, provide to these brilliant students that are jumping topic to topic, but actually there's so much in thinking and methodology and process. And it's quite hard to quantify because it's these little nuggets that come from experience that could be applied in that end of life. But it reminds me of something that in one of our discussions in healthcare systems, part of my research is interested in just improving the experience. And I was very nervous of presenting that idea to healthcare providers, so to chief medical officers or whoever's in the room, because it's separated from healthcare outcomes. And a lot of healthcare research is about improving the outcome in terms of the quality of life of the patient, or in terms of the actual survival, for example, or the length of their life expectancies, surgical interventions. And I have a view that actually the experience of care can be improved and separated from that healthcare system. And I think that is almost what you're saying from that palliative experience.
Yeah, there's many stories around that space, but you shouldn't be afraid of it, because quality in healthcare is measured as clinical and cost effectiveness, patient safety, and patient experience. Now, it's strange, it doesn't say anything about the staff experience or staff safety, which it should do. So those three core pillars of quality are what's expected. Now, of course, any hospital, any CEO is expected to report back on mortality figures and all sorts of numbers back to government to say how well they're performing. But there's also that desire to say, well, we don't want people to come back into the hospital after they depart. And the experience they have, the motivation they have, the quality of that journey through the hospital can have quite an impact on whether they return again. And it's something that when you talk to individuals along the care pathways, what you realize is that everybody in the system is trying to do the very best for the patient. And yet some parts of the system are antagonistic to each other, which means that the experience isn't always the way it should be. And it really is that systems joining up of things that really matters. And part of it too is making sure that the pathways as designed understand the dimensions of the population that they're there to cope with. So one of the things we've been doing in palliative care is looking at how do we create a set of personas for end-of-life patients. And it sounds like a really difficult thing to do, but I've got an extraordinary team here, including a senior nurse who's involved in palliative care and interviewing people at end of life to try and understand who these people are. So we come up with a set of personas that capture, and we talk about the dimensions of variation that matter. And can we describe in maybe 8 people the boundaries of the population that we're trying to design the pathway for? And then we can work with the care providers and say, look, these are the people that we're trying to serve. Are the protocols and processes and procedures adequate to do that? Because the storytelling is a brilliant thing in health and care. That it really helps us understand the diversity, but it's not often used. So if I was going to go to a surgeon and say, what do you do? Well, that's not the right question. You get the stock answer, I fix bones. But if you say, well, tell me about the last patient, tell me about the really difficult one, or tell me about the one that went really well, or tell me about how the team upstream can do things that would help you do what you do. And the interesting thing is to ask the surgeon, well, what do they need to do to make it easier for the patient to rehabilitate? And you can start seeing the stories come out and start joining them up and starting to see how much they appreciated the system before and after them, or how much they're focused on what they do. And it's a great way into then saying, well, let's now think about the patient journey. Let's think about the variety of patients, the different challenges they bring.
Yeah, it has been so refreshing to hear someone else talk about design in this way that is so poetic, that talks about that you are talking about the stories behind it and how powerful the methods can bring people together in very difficult situations. Not only talking about palliative care, but also systems and and opposing views as well, different key stakeholders with opposing views. And that is quite refreshing also to hear. I'm going to shift gears a bit because I know that we can talk about the beauties, but also I know that designers often work with engineers and with users as well, observing and understanding their needs, as you were saying, right? Like you're talking about working with the nurses and the doctors, but what about talking and co-designing with the users? And preferably, that's what people mostly do. In healthcare, we know that there are many processes bringing people together, people or carers with lived experience. What are the approaches that you use to involve the users, and how easy is that to bring users to be testing your the system that you are designing with?
Really interesting set of questions in there. And I think if you look back at the original Engineering Better Care report, it talks about understand, design, deliver, sustain. And one of the things we learned by working with people in practice is there's a stage even before that, initiate, where you start to bring the team together. And that's the beginnings of where co-design happens. Is saying, have we got the right representation in the room? And we also changed design to co-design. And we wanted to accentuate the involvement of people in that part of the process, but actually it's co-everything. And it's about co-understanding, co-design, co-delivery, co-sustain. You can't really just think about it as the middle part of the process. We did that really more for convenience to make sure we captured that perspective. Generally, it's easy to find patient representatives. So almost any disease area, any demographic category around the UK, you can find patient groups that represent the interests and needs of patients. That's straightforward because the ethical processes to engage those people are relatively straightforward and not much more challenging than it is to talk to a physician. If you want to talk to real patients, part of the challenge is you have to go through the full ethical process, and quite rightly so, before you get access to patients. So one of the first decisions you make is, do you work directly with patients or do you work indirectly with patients? And the challenge is often not so much in working with the patient representatives, it's finding an even-handed representation of physicians across the whole journey. So it's much easier to get hospital physicians given some time to be released to do improvement. It's much harder to get a GP to release their time to do improvement. And in fact, it's often on their own cost. So unless you've got a funded program that can provide money to the GPs to buy them out of sessions, it's much harder to get access simply because the funding model is very, very different. And in working Cumbria, we probably have one GP for every 5 hospital physicians. And that wasn't unusual for that type of program, but nonetheless, really important to get the different voices in play. I think co-design, in its raw description, is often misunderstood as saying that now we know what the problem is, I need help in co-designing a solution that's fit for purpose with the patients. For me, that's way too late. The co-design starts when you're still struggling to understand what the problem is. You're still lost in the fog. So many moving parts. You don't quite understand what's going on. And that patient voice, that lived experience will tell you things that the physicians can't. That maybe the carers can, maybe the visiting nurse at home can see. But you need that insight. You need those narratives to start the co-design process in the left-hand side diamond of the double diamond, in that translation of need into the problem statement. And I would say that the systems approach that we've been developing has way more power and relevance in the first of the 2 diamonds, the problem seeking and the problem solving. I think if you can really successfully nail what the problem is, the people you've got in the room are often best placed to co-design a good solution, and it's in their territory. If you don't get the first diamond right, you're always going to be on the back foot. And so what I'm always saying now to healthcare professionals or policy professionals who we train as well is that What we're really trying to do here is to find appropriate solutions to the right problems. And it's that first diamond is the one that is most important and where we can add, I think, the most value.
And we should quickly say the double diamond is that problem exploration and formulation, or reframing of the problem, and then solution exploration and bringing that together for solution definition. And that, sorry, excuse me. And that's really, I think you've said that really, really elegantly and really beautifully explained how they're brought together. Just returning back to your systems, risk, design, and people, how would that fit within the diamond? So is it at the problem phase, or would you also repeat that in different parts of the process?
Yes and no. It's, of course, improvement is different from blank sheet of paper design. And there's a subtle difference in the way we train people often. And if we start with a blank sheet of paper, what we often do is to say, look, what is the contextual system you're trying to design something in? What's the system in outline from what you're trying to design? Then you do the design bit and then you risk assess it. Or if you're doing improvement, we often do it the other way around. We say, well, can we describe the system? Can we poke and prod it and take a risk-based view? And then can we redesign the bits that matter? But the risk-based view is double-ended. So the old-fashioned way of thinking about risk is, well, what could possibly go wrong? It's in the engineering world, it's a proactive thing. It's different from healthcare because healthcare says something went wrong. What caused it? We need to know so we don't let it happen again. Engineering would say, well, what's the event that happened? How many different ways could we get to that point? And what failure would result in harm? And how do we design those out before we put the thing in service? But at the other end of the spectrum, risk is also about saying, what do we do that's extraordinary? What's the best we can do? And how do we repeat that? How do we learn from it? So risk is really about shifting the outcome curve towards the good end, avoiding the accidents and replicating the best things you can do.
Yeah, that's I think that really exemplified how the engineering way of thinking or tackling technical systems can be applied to managing and supporting and reducing the risk actively in there.
But to answer the rest of your question, Simon, because you can do the risk very early on in the problem-seeking phase. And I've seen that done really well. And then I've seen somebody come up with a solution which they don't risk assess. So risk assessment is cyclical. It starts early on. It can inform what you should be doing, but it should also be used later on to inform the design and delivery and ongoing monitoring of what you're doing. So these things come around. It's certainly not a linear process.
If it's not a linear process, as you were saying, because it is iterative and you go back to the people, to the systems, to the risk, to the design, and you're involving many people in the process, where, and I'm going to ask you the question that you asked to your team, like not in the delight part, but like, where do you call it success? When do you think that, okay, this is enough iteration that we reach a point where we have spotted the risk, we have co-designed and co-created some of the solutions for some of the problems that we have uncovered? Where do you call it, this is a success and we're going to be implementing this? We can keep going and going in this process.
It's a good question. When we ran a series of workshops up in Cumbria, we quite naively thought there was an initiate phase, which we named after the event, where we just got the teams together and started to formulate the challenges that we're going to look at. And then the next big workshop was about understand. So it was all about the rich pictures, the stakeholders, trying to tease out what the narrative challenges were. Then we ran a co-design workshop. And towards the end of that, I just said to them, okay, we're expecting now that next time we meet, we'll do deliver. We'll understand how we translate those designs into actual practice. And that's fine. So 3 months later, we come back together. At the beginning of the workshop, we said, we're actually going to go back to the understand phase. You thought we were going to do that delivery. We will talk about that, but let's go back with what we know now and all the work you've been doing behind the scenes, and let's revisit the understanding, the definition of the problem. And it was an extraordinary sort of collective sigh of relief in the room that people have thought of it as a linear process. They always were used to doing it as a linear process. And nobody had ever given them permission to go back and start again. So we spent a whole morning going back and revisiting that early phase and saying, well, what has changed given what we now know? And we let that ripple forward again. And then the pragmatics kick in to say, well, how often, as you say, can you iterate around? It has to be set in the context of how long have you got these people released for to do this project. So we did one iteration. It was transformative in just nuancing and detailing what the requirements should be and focusing down on the things that mattered. And then we went forward again. And we went into the delivery phase and they started applying some of these challenges. So I think what was most important in all of that was that permission to go backwards. In the same way that when we fill in the canvas, I always say to them, look, it doesn't matter where you start. If you think you have the idea in mind, the solution, write it down, because that will help us understand the problem better. And Saeema, you'll recognize this. Ken Wallace, who taught us both at different stages, Ken said to me at one point, said, look, John, you only really understand the problem when you've got the right solution. And we were always taught that Germanic SEAL process of design, and it cannot be further from the truth. That you need to be able to iterate at multiple stages. And sometimes a double diamond helps you in that because it's just 2 stages. But you have to have the courage to flip back again. For me, one of the things that really captures this is that when you talk about the qualification of what you've done, you can talk about evaluation, but the pharma industry helps you out here because they talk about verification and validation. And verification is, well, does your solution meet the requirements? Validation says, is the solution fit for purpose? And in all the pictures of that, the one thing that's missing is the validation stage that says, look, does my problem definition describe something that would be fit for purpose? Because if you give the problem to the team to solve or give you a solution, but if the requirements are not quite right or quite focused enough on the patient or whatever, you're not going to solve the right problem. So talking then about validation of the requirements forces you to think about iteration again. So that as you learn more, you have to be able to go back. So has that changed what we should be doing? Has it improved our understanding? But really tough to do in the confines of a program where people are expecting to move forward week after week.
Yeah, it's really interesting how you've presented that with the buy-in from your workshops and experience and their sort of sigh of relief to return to the problem and see it reframed. From my experience, it's been quite interesting. I spent a year working with physicians and people across the healthcare systems and patients and carers with lived experience, particularly of multiple conditions. And there was a resistance of reframing the problem. And they actually resisted the idea of engineering design. This was not really from the patients and carers. It was coming from the physicians and the medical professors who didn't like the idea of engineers coming there and saying this is what the problem is because they diagnose problems, right? So that's where it started. But within a year, we've won them over. I mean, hopefully we won them over earlier in that journey, but that approach can be quite challenging for disciplines who aren't used to that approach. So it's really great to hear your experience has been quite different. It sounds like it's been very welcomed.
It has been, but I don't think you turn everybody's head.
Yeah.
There's always a physician who comes to the clinical engineering team saying, I need one of these. And you sort of naturally ask, well, why do you need one of these? And at the end of the conversation, the only thing you can deliver is one of these. There's no leeway. The physician knows the answer that they want. There's other physicians that will start to explain to you why they need one of these. And after a long conversation, well, actually, you need one of these. And it's something different. And the conversation's led to a deeper understanding of what the challenge is and what a variety of solutions might look like. And I think it's one of these natural things that some people can just think more in that way than others. And the more success stories we have, the more systems-based success stories we have, the more people may be looking to say, well, we need something that they were doing. We need to copy that. And even if you don't solve the problem, sometimes you take some of the antagonism out of the space. And there's a really good example of that when we were looking at discharge flow of patients from hospital back into the community where they needed care in the community. And we were asked to go in with the Royal Academy of Engineering to map out that process. And the first thing we found is that nobody could tell us what the process looked like. And even the national experts couldn't tell us what the process looked like beyond about 3 or 4 boxes. So we ended up going out to about 43 different people set around this process, asking those questions. Tell me about the last patient. Tell me about the different challenges, and building the process out of the fragments. And from an engineering point of view, you can immediately see where some of the challenges were. And we then overlaid patient journeys onto that map, and that told us even more. But one of the things that came out, which was fascinating, was that a patient with a care package goes into hospital for elective care. And after 48 hours, they forfeit their care package. And it might be only a day later, they're medically fit to go home, but they need care. So you've got this challenge that the patient care has disappeared, and you're pointing the finger at the people in social care, but they trying to the best possible ability use the minimal resource they've got to the maximal advantage of different patients. And once the folk in the hospital started to understand that they're both motivated to serve the patient, but facing different directions, that understanding crept in, and that desire to say, look, yes, we're not going to blame them anymore, but how do we work together to solve that? And then the big challenge is, well, yeah, but where does the money come from? Where does the challenge come from that these people are following, quite rightfully following? And that's the bit I think is most interesting, but most difficult to fix in health and care, is that disconnect between social, primary, public health, secondary care, tertiary care. The funding models lead to antagonistic practices. And one of the challenges within that you find as well is that people are always saying that we need to take waste out of the process. We need to be more efficient. And they target different parts of the pathway and they try and lean them out. One of the things I said back to the team leading this was that if you keep trying to lean out or optimize individual parts of the process, you will not be able to optimize the whole. And that took a lot of getting across, but it's something as an engineer you see in multiple systems. You have to understand how to optimize to get the best out of the system rather than the best out of the individual parts. And that is not a concept that was well understood in a fragmented, disconnected health and care system.
I mean, the bit that you've highlighted on the care and bringing people into the hospital and leaving the hospital is very interesting. And returning to the point that you made, Melissa, on the stories, and I remember an exercise we did when we were in when I was in Denmark, actually, with their tax system, and the power of stories was used to highlight to the tax system that people aren't just a number. And I'm just thinking in this system, what we've understood in that it can be quite challenging to bring people into the hospital. But once they're there, they're no longer just a number for those providing the care. They're a person with a story, real life person right in front of you. And bringing them out of that system is changing them back into a number. And that can be quite difficult. So you could see why that happens, because it's like a flow of connection, but it's also that power of story and the responsibility to look at the other parts of the system and the people who are being just thought of as numbers each side of that episode of care. But let's return to the funding bit, because that's quite a challenging part. So one of my medic friends in Scandinavia, sort of looking at the UK system, highlighted it as a pot. So we have a little bag of funds, and if we're in the private healthcare system, each time we have engagement with the healthcare patient comes in, we're adding to that pot into that bag. In the UK system, we're taking out each time we're entering the NHS systems. And I think you've highlighted already, there's this organizational flow of and boundaries, and they can be between the different parts of care, the primary, secondary, and social care, but they can also be within secondary care, the way our medics are taught. It could be around a particular disease, particular discipline with budgets assigned just there. So within the same hospital, you have budgets that are separated. We have flows of organization boundaries, but that's also flows of information that are bounded in that way. So if we had to rethink healthcare, we recently had the report from Lord Ara Darcy on the NHS, and it focused around a few different areas. One was shifting to prevention. Two is moving the care into the community through the neighborhood hubs, for example, and a greater use of technology, including the use of digitalization. Now, given those boundaries that we've talked about, this seems quite challenging to see how do we address this. And one of the exercises I've done with people in the healthcare system and people with lived experience is say, we've got a magic wand, and after we've gone through the problem framing and all of this, imagine everything's taken away. What's this system going to look like? So, John, over to you. What will this system look like? And where are engineers in this? Where's the engineering design role?
So I think it's a really interesting proposition. The three shifts to the left are all understandable, and there are things that need to be done, but they need to be done with good grace in a sense that we cannot leave people behind. And particularly the technological shift in going digital has the potential to exclude not just patients and the public, but also healthcare providers. So we have to think about the mechanics of that. And the following 10-year plan equally has a lot of powerful messages in there about how we make those three shifts to the left. The challenge I see is that every one of those is part of a complex system. And we really need to have systems understanding, systems leadership in place to understand how we do that in practice. And one of the simple things that I often do is to say, well, when we're talking with the team about the patient journey as the priority, what does that journey, what does the experience look like, and how do the fragments of pathways fit around that? I say, well, what do we really want this to be? Let's dream a little. Let's figure out what the best pathway needs to be to give us the best journey. And that gets us away from saying, oh, we can't do that because otherwise you're always bounded by the constraints within each part of the pathway to there. So we're saying, well, we've got the team in the room. From a patient point of view, what's the best we could believe we need for tomorrow? And then you come at the constraints from the other side, because you then say, well, what can we do that starts us on that journey of improvement? Accepting that there are constraints. There are many big challenges that we have to figure out, one of them being the funding, the money flow. But if the aspiration is to go beyond the current boundaries, you can at least start that progression. And sometimes what you can even do is get the teams either side of a boundary to together change things that mean that it almost doesn't matter that the boundary is there. But you have to have that ability to dream. And the integrated care boards who sit above the different parts of the system, part of their role is to see that as one whole system. It's going to be difficult to catch that in a way that makes real change until we tell those stories. So maybe come back to storytelling. One of the things we did in Engineering Better Care, and I've seen done elsewhere, is you tell two stories about the same person. You tell their journey through the system as is, and their journey through the system that you would like to have. And they show such a difference in terms of that experience and the delight that can come in a difficult experience. You've got something to go back to the politicians and ministers to say, yes, there's data. Yes, it's about information. Yes, it's about the money. But it's actually about the lived experience we are plotting and planning to give to the patients and the public.
No, that's
Definitely.
really powerful. I wonder if that's a good point to try and wrap up. And just thinking through, I'm going to just say what I think what my takeaways are coming from what we hear. One is we hear, well, there's quite a lot in there, but there's a power of design in thinking about people first and problem first and reframing and really trying to understand that problem in there and not being afraid to return to that. I think you've also highlighted the power of stories. And that's partly through what you've just talked about, thinking about personas, but also thinking about people and their journeys, both as how you would like it and what the current challenges can be. But the third message I've picked up from your response to that magic wand, that even without changing the system overall, without changing the funding model, but thinking of those as constraints, there is still a power and ability to bring together people through these systems approaches to redesign parts of experience of care to improve that to be patient facing or even healthcare provider facing. Is there anything else that you would like to add to that, John?
Well, I think it really is about coming to that common understanding of the whole journey that the physicians or public health professionals, what they're part of. And I've never come across healthcare professionals who are not trying to do the very best. And it's really trying to help them and their bosses and their bosses' bosses to set the priorities in a way that enable changes to improve care. So it is a whole system challenge. And it is very much about leadership. We need people in play who understand what it is to deliver better systems and not just better fragments of practice.
That's a really very important bit to include in there. So thank you very much, John. And we are excited that in the next episode, we're going to bring John Kermith, an entrepreneur and also a general partner and co-founder of London Green City on the banks of the Thames in London, who supports and identifies startups to help them to scale within the UK. Thank you.
Thank you.
Thank you for listening. We hope you enjoyed it. Let us know what you think, or if you have an idea for a future guest or topic, at www.decodedpodcast.com.
Don't forget to give us a rating wherever you listen, and follow us on TikTok and Instagram at decoded.podcast. See you!